everyone. This is Group 1 presenting Case 1. 6-year-old John presented in the accident of emergency department with a 2-day history of malaise, fever, blood in his urine, and a puffy face. He had no history of a renal disease or abdominal trauma. Medical history of note was a sore throat some 12 days before, which had settled without a visit to his GP. His mother remembered that he had received the standard immunization schedule. On examination, John was febrile, had periorbital and ankle edema, and his blood pressure was 130 over 90 mmHg. The skin on his face and trunk was peeling and hadn't tongue. The rest of his examination was unremarkable, and investigations are shown on Figure 1, which will be presented in a minute. A diagnosis of streptococcal glomerulonephritis was made, and John was started on benzyl penicillin. His fluid retention was controlled by restriction of salt and water intake and giving him loop diuretics. Within a week, his blood pressure had dropped to 105 over 70 mmHg, and there was no hematuria or proteinuria. Several weeks after presentation, his C3 level had returned to normal. At follow-up, he was well and had no signs of renal impairment. So, post-streptococcal glomerulonephritis was first recognized as a complication of the convalescence period of scarlet fever in the 18th century. It is a kidney disease that is most often occurs in children ages 6 to 10. This is a result from a bacterial infection, which is from specific strains of group A beta hemolytic streptococci called nephrogenic streptococci. This disease causes rapid deterioration of the kidney function due to an inflammatory response and affects the glomeruli and the small blood vessels of the kidneys. It usually goes away by itself after months, and in a small number of adults, it may get worse and lead to a long-term or chronic kidney failure. Sometimes it can progress to end-stage kidney disease, which requires dialysis and kidney transplant. PSG only presents in children 1 to 2 weeks after a streptococcal throat infection or within 6 weeks following a streptococcal skin infection. Just like John, he has a medical history of a sore throat 12 days ago, which was settled without a visit to his GP, thus leading him to have a streptococcus bacterial contamination. His results of investigation shows macroscopic hematuria, that means blood in the urine, causing him to have discoloration or causing it to have discoloration. It is often possible to stop or prevent the spread of the infection by preventing group A streptococcal infection and practicing good hygiene, such as washing of hands. Next slide, please. Moving on to the etiology, acute post-streptococcal glomerulonephritis follows infection with only certain strains of streptococci designated as nephrogenic. The offending organisms are virtually always group A streptococcus. APSGN follows pyodermatitis with streptococci M types 47, 49, 55, 2, 60, and 57, and throat infection with streptococci M types 1, 2, 4, 3, 25, 49, and 12.
So the next one is the patient characteristics or the signs of symptoms of patient who has post-streptococci glomerulonephritis. So these are the common patient characteristics. First is dark reddish brown urine. So this is often the first clinical manifestation of PSGN. So dark urine is caused by hemolysis of red blood cells that have penetrated the glomerular basement membrane and have passed into the tubular system. Next one is edema or swelling, so especially in the face, around the eyes, and in the hands or feet. So periorbital edema, as what John has shown, is very typical. So the onset of puffiness of the eyes or eyelids is sudden. So it is usually prominent upon awakening. And if the patient is active, it tends to subside at the end of the day. So in some cases, generalized edema and other features of circulatory congestion, such as dyspnea, may be present. So edema is a result of a defect in renal excretion of salt and water. So the severity of edema is often disproportionate to the degree of renal impairment. So next one is decreased need to pee or decreased amount of urine. This is also known as oliguria. And the fourth one is fatigue due to mild anemia. So anemia is actually a common early in the disease and primarily due to the dilution, although in two instances. First one is autoimmune hemolytic anemia was documented in the early stages of PSGN. So anemia tends to resolve with diuresis. So a few patients may have diminished erythropoiesis in the recovery phase and have some persisting anemia. So other common complication having PSGN is hypertension with or without central nervous system manifestations. So as you can see in the slide up here, the first image shows edema in the feet. The second one is the redness of tongue, and the third one is the puffiness of the eyes and the eyelids. So these are actually the most common patient characteristics of patient having PSGN or post-streptococcal glomerulonephritis. So next slide.
Now we move on to the discussion of the laboratory findings and the tests that were involved. So the patient did a couple of tests, including a complete blood count, serum test, urinalysis, and blood culture, among others. So we will go through this one by one, starting with a complete blood count test, where we can see that the patient's hemoglobin and serum albumin are lower, while the white cell and the platelet count are within the normal range at 10.41 and 10.1 respectively. And his hemoglobin level is lower than the expected normal range at 10.41 and his serum albumin at 31 respectively. So post-streptococcal glomerulonephritis is a rare kidney disease that can develop after group A strep infections. So group A streptococcus bacteria is the bacteria that's causing the infection, and it must acquire iron from the host to establish infection, as stated by a journal article by Actor et al. 2020. Hemoglobin, the largest iron reservoir in the body, is obviously affected by the presence of this bacteria, since it feeds on hemoglobin in order to develop infection. On the other hand, the decrease of the serum albumin levels of the patient can be explained by two reasons. First, it may be a result of decreased production of albumin or increased loss of albumin through the kidneys, as post-streptococcal glomerulonephritis is an infection that affects the kidneys. And second, it may be caused by the binding of the streptococcal bacteria with the human serum albumin for its survival. So basically, it's for the bacterial survival. That's why the serum albumin levels of the patient has decreased. Furthermore, the patient has also done serum tests where we can see his potassium and his urea levels are elevated, while his sodium and chloride levels are within the normal range. The elevation of the patient's potassium levels or hyperkalemia is caused by is a normal complication of post-streptococcal glomerulonephritis, as stated by Mount Sinai Organization. Moreover, the patient has also done urinalysis, where common findings of people with post-streptococcal glomerulonephritis are seen, like hematuria, granular cast, and most especially RBCs that are often seen on people with problems on their glomerulus. The patient also did a throat swab where Streptococcus pyogenes are seen, obviously because he has already infected the Streptococcus bacteria. And the patient has also done anti-streptococcal antibody tests where everything came out positive. So from the findings of the laboratory test, the patient is confirmed to have infected the group A Streptococcus bacteria that has caused him a rare kidney disease called post-streptococcal glomerulonephritis. That's all for the laboratory findings and tests.
And for the next slide, it will be the clinical hypothesis. So the patient presented with hematuria associated with chronic renal failure, and the patient had monoclonal gammopathy of undetermined significance, and one had smoldering myeloma. So the serum monoclonal IgG was associated with light chain proteinuria, and deposits were intramembranous, subepithelial, and mesangial by electron microscopy, and stained positive for C3, properdin, and CPH, but negative for IgLC and heavy chains, and that would be C4 and C1q by immunofluorescence. So GN with isolated glomerular C3 deposits might represent an unusual complication of plasma cell dyscrasia related to complement activation through an autoantibody activity of the monoclonal Ig against a CAP regulatory protein. And for the pathophysiology of the disease involved, so the disease is immunological, representing a type 3 hypersensitivity reaction. So the exact mechanism by which PSGN occurs is not fully determined, and the body responds to nephrogenic streptococcal infection by forming immune complexes containing the streptococcal antigen with a human antibody. And some theories suggest that these immune complexes become deposited in kidney glomeruli reaching through the circulation. And others claim that the condition results from an in situ formation of the antigen antibody complex within the kidney glomeruli. So the presence of immune complexes leads to the activation of the alternate complement pathway, causing infiltration of the leukocytes and proliferation of the mesangial cells in the glomerulus, thus impairing the capillary perfusion and glomerular filtration rate. And the reduction in GFR can lead to renal failure like oliguria and anuria, acid-base imbalance, electrolyte abnormalities, volume overload, edema, and hypertension.
Okay, so we have questions up here, follow-up questions regarding with the case. The first one is the pathogenesis of post-streptococcal glomerulonephritis, which is related to the pathophysiology of this disease. So PSGN, again, follows infection with only certain strains of streptococci, so designated as nephrogenic. So this was mentioned earlier that the offending organism have virtually always been grouped with group A streptococci. So acute PSGN follows pyodermatitis with group A streptococci that have surface antigen M proteins 47, 49, 55 to 60 and 57, which was mentioned earlier again. So less often group C streptococci may be involved in this disease. So many morphological, clinical, and serologic features suggest that PSGN is an immune complex disorder, in which an immune complex containing a streptococcal antigen is deposited in the affected glomeruli. So the size of glomerular basement membrane pores and the molecular size of the streptococcus Ig complex are also important determinants. So the molecular size of the Streptococcus Ig complex is about 15 nanometer, 10 nanometer for Streptococcus group A, and 5 nanometer for immunoglobulin. So the GBM pore size, or the glomerular basement membrane size in children and adults, are 2 to 3 nanometer and 4 to 4.5 nanometer respectively. Therefore, the immune complex molecule can more easily rotted in the glomerulus in the children than in adults. It means that since the glomerular basement membrane has a smaller size in children, these immune complexes are tend to stock in the GBM compared to adults, which has bigger size. So it was also determined that in PSGN and other type 3 hypersensitivity reactions, vascular endothelial cells in the kidney actively transport circulating immune complexes from the capillaries to the peritubular interstitial space, where they are detected and scavenged by the resident macrophage. So uptake of the immune complexes by the resident macrophages triggers the release of pro-inflammatory cytokines, which in turn result in recruitment of monocytes and neutrophils into the kidney from the circulation. So there are two antigens isolated in nephrogenic streptococci that is very common. The first one is the streptococcal pyrogenic exotoxin B, or most commonly known as SPEB, and the other one is the nephritis associated plasmin receptor, which is NAPLR. So both antigens bind with plasmin, protecting it from physiological inhibitors, and thus could cause chemotaxis of inflammatory cells and degradation of glomerular basement membrane. So these two can be found in the glomerular post-streptococcal Streptococcus glomerular nephritis tissue. Yeah. So next question is.
Yeah, so the next question is, what is seen if a renal biopsy from this patient is stained with anti-IgG and anti-C3 antibodies conjugated to fluorescein? So post-streptococcal glomerulonephritis with severe proliferative and exudative GN. So the glomerulus is enlarged and markedly hypercellular with a large number of neutrophils. And note that the red blood cells in some tubular lumens and hematoxylin and iosine stain with the original magnification of 200 times 200, and post-streptococcal GN with proliferative and exudative GN. And the glomerulus shows endocapillary hypercellularity with multiple neutrophils, although far fewer than the glomerulus. And there is a granular staining in the glomerular capillary walls and mesangium in a starry sky pattern. And the glomeruli show in the light microscopy, the glomeruli show hypercellularity like in endothelial, mesangial, and inflammatory cells, which are non-specific. In electron microscopy, the most characteristic finding is the presence of subepithelial humps, which are electron-dense deposits in the subepithelial space near the glomerular basement membrane. And for the immunofluorescence microscopy, evidence of IgG and C3 deposits in the first 2 to 3 weeks of the disease is present.
So,
Yes, and for the next.
so what is the long term of this condition? So as to what I have said earlier, This disease usually goes away by itself after several weeks to months. It may get worse and term or chronic kidney failure when it comes to some adults, thus progress to end-stage kidney disease, which requires dialysis and a kidney transplant. The prognosis of PSGN in children is very good. More than 90% of the children full recovery, although adults with PSGN are more likely to have come due to a residual renal function impairment.
Last question is, are all strains of group A streptococci equally pathogenic? The answer is yes. All strains of group A streptococci are equally pathogenic for the reason that Streptococcus pyogenes, or the group A streptococcus, is an important species of gram-positive extracellular bacterial pathogens. This type of bacteria colonize the throat or skin and are responsible for a number of suppurative infections and non-suppurative sequelae. As pathogens, they have developed complex virulence mechanisms to avoid host defenses. And they are the most common cause of bacterial pharyngitis and are the cause of scarlet fever and impetigo.
So yeah, so that is it. That is our presentation for post-streptococcus glomerulonephritis.
Once again, we're the group one, and thank you for listening.